Yeah, good morning, class. I wanted to wish you guys the best of luck on your comprehensive exams. I know these could be very challenging, but I know you've put in the hard work all this time and effort you spent. So I want you guys to do really well and relax. Just trust the information that you guys have been given by your instructors, and you should do fine. So if anything, you'll find out where you need to concentrate on, for your board exams and find out where your weaknesses are. And we tend to study the stuff we're comfortable with. Oftentimes, even myself, I find myself in school and I like to study everything over and over again. But however, if I look at the same, flashcard and I keep doing it, I should put it in a different pile if I know it, right? And just concentrate on the stuff that I don't know. So good luck with that. And so that's why we're here on this pre-recorded lecture, is to give you guys an opportunity to look at this at your convenience for next week and potential for the following week as well. But I'll get some feedback from you. Last week, we covered the cardiovascular exam. We covered the echocardiography, stress testing we talked about, cardiac catheterization, showed you what that looked like, chest pain. Also, we talked about edema, pitting edema, and man, how that looks like Play-Doh, once you palpate on those shins, especially after somebody takes off a cast. Really starts to pit pretty bad. But I'd like to also, talk about potentially in week 3 of cardio, we're going to get into atrial fibrillations and readings of the EKG. I want to send you a link for a website that'll allow you to go through a series of classes. And some of them are paid memberships, but it's really cheap. You can, figure that out, and you can get proficient at reading EKGs. So if you have interest in doing that, give me a thumbs up. And if not, just let me know, and I won't send it to you. So let's go ahead and get started. All right, let's get started. This week, for week 2 of cardiac, we're going to talk about palpitations, syncope, orthostatic hypotension. I know that came up a few times last semester, so we'll just go ahead and do a quick review. We're going to talk about hypertension and drugs associated with hypertension, what you're going to be seeing in clinic. Also, hypertensive emergencies. Hey, when should we not treat a patient? What are the red flags? And so those are important to remember, so foot stomp on that one. Also, we're going to talk about atherosclerosis, coronary artery disease, angina, and heart failure. Okay, so as we know, palpitations comes up a lot with Chinese medicine. We can treat it. We can treat palpitations. And it either comes from the PC or heart, right? So we experience this in the clinic as well. People have an increased heart rate, and it's actually a perception of cardiac activity, right? So it's fluttering, racing, skipping sensation, and it usually reflects changes in the cardiac rate or rhythm. Perception is highly variable depending on the person's shape, whether this person is happy, sad, whatever the case may be, but it's often heightened in sedentary or anxious or depressed people. So keep that in mind as well. And as with Chinese medicine, we have the Shen, right? So if you have a disturbed Shen, or feeling a little low, there's your depression right there, right? So we'll just keep mentioning and having, we'll reflect back to Chinese medicine as much as we can if we can find some commonalities. But, and definitely it'll help you with your studies. So the etiology, the most common is premature atrial contractions, premature ventricular contractions. So either or, either atrial on top or ventricular on the bottom chambers, right? So you can have, those are the most common, and both are usually harmless. You know, it is just, this pain or this, it's not necessarily pain. Some can be painful. So if you pause the video right now and if there's, look up when is it painful? Go ahead and pause it right now and come up and email me back. Let me know when palpitations are painful. Something for you to study on your own. Let's go ahead and pause the video. And okay. All right, so that may have been very obvious for you that palpitations, when they're painful, come from serious cardiac causes. It says it right here, serious cardiac causes. So you've got your myocardial infarction, which we'll cover in depth in week 3. Also, congenital heart diseases. Okay. Also, valvular heart diseases. Some drugs that speed up the heart rate, like digitalis, which is a group of medicines from the foxglove plants, right? So we should be reading about that. Maybe try to look that up in our Chinese herb pharmacopoeia. See what you find. It increases cardiac contractility, right? So does caffeine. Alcohol sometimes gets involved with that as well. Also slows down the heart as well. Nicotine. Some people, when they drink alcohol before they go to bed, they wake up because they have an increased heart rate. And so we got to really watch it. If we drink alcohol, try not to drink it right before bed. Also, nicotine will do that, the same thing to you. Etiology, the most common, as we covered. Evaluation, history of present illness, frequency, duration, and provoking factors. Got to get that frequency. How many times does it happen a week? How many times does it happen a day? How long did they last? And hey, was it increased by exercise, or just happen at rest? If there's syncope involved, lightheadedness, chest pain, dyspnea, you got to note that, right? So that's your HPI. When you do a review of systems, you want to ask about heat intolerance, weight loss, tremors, chest pain, dyspnea on exertion. So that's the key point on palpations, right? So if you have dyspnea on exertion, right? And also if you have pain when you have angina during exertion, or if you have angina at rest, that'll come up again when we cover angina. But consider those factors and look for those in test questions as well. You want to make sure you want to ask them about their fatigue, if they've had heavy menses or melena, and their past medical history, right? Do they have a history of arrhythmias, heart or thyroid disorders, specifically hyperthyroidism, right, which is an increased heart rate. Family history, do they have a family history of palpitations, and drug history. Also, get their over-the-counter drug history as well. Don't just get their prescribed drugs. And it's kind of a sensitive thing to ask, but you can, when you get around to that history, you may want to ask, hey, do you take anything else? Do you self-medicate for anything? What makes you feel better? And they may tell you that they smoke pot, and go ahead and annotate that, but that's a sensitive issue, and that we'll get into that when we cover medical history and obtaining someone's history. Evaluation. So we have our physical exam, right? We want to note their demeanor, whether they're anxious or agitated, take their vital signs, right? Orthostatic BP, which we'll cover here again. We're going to talk about the milligrams of mercury on one side or the other when they stand up, and what constitutes orthostatic BP. We want to take a look at the jugular pulse waves. So jugular pulse waves are essentially when you can actually see it mainly on the right side. So because it sits right above that atria, right? It's a direct shot straight up. So we want to take a look at that. Thyroid enlargement, We want to inspect for pallor, cardiac auscultation, and also we're listening for murmurs and different things like that when we auscultate, right? And we want to do a neurological exam, including the reflexes. Going back to orthostatic BP, there's other things that we can do, like a tilt table test occasionally called the upright tilt testing. And it's a medical procedure often used to diagnose a dysautonomia or syncope. But we have a syncope section here that we'll talk about too, that this will come up. So here's one of the tests they can do for this to check out that pulse in the jugular vein, right in through here. So again, it's straight up from the right atrium, right? That's why it's so significant on that right side, okay? The patient's right side. So here's the mandible, right? So right around the same level of the mandible, you'll have the highest level of pulsation. And then there's this figure. They get the sternal angle of Louis, all right, and the depth to the right atrium is 5 centimeters, and they figure out this pressure. And there's a figure that goes into that. It's not too important for our medicine, but this is what they're looking at as far as vein pressure from that right atrium up. All right, let's talk about palpitations, the red flags involved with that. So you're going to have lightheadedness or syncope, chest pain occasionally, right? So when they have chest pain, it's always a red flag, right? When they have difficulty breathing, it's always a red flag. And new onset of irregular heart rhythm. And then you have your heart rate, okay, greater than 120 beats per minute or less than 45 beats per minute while at rest. Okay, significant underlying heart disease is always a factor when combined with any of these others. Family history of sudden cardiac arrests also, and exercise-induced palpitations or syncope is very important right there. I want you to put an asterisk on there. So there will be test questions on that. Okay. So some of the testing involved, right, is your ECG and also possibly even a Holter monitoring for 24, even to up to 72 hours, where the physician wants to get a good look at what's going on with your ECG. And it's just a little device they wear around your neck, looks like a neck wallet. It's sitting and it has leads like an ECG does, but it's not a 12 lead. Most of them aren't 12 leads. But there have been ones that with modern technology, they're getting better and better. So even some of the Apple Watches are pretty cool. They can take your ECG with certain, the technology is getting great out there. So yeah, another testing, you can do a complete blood count or serum electrolytes, right? Serum electrolytes. So when we're talking about serum electrolytes, what are we looking at? And so how does serum electrolytes affect the way our body functions? Just remember that electrolytes are minerals, right, in your blood. So, and other body fluids that carry an electrical charge, electrolytes actually affect how our body functions in many ways, right? So it affects it in the amount of water in your body, controls the amount of water in your body, the acidity of your blood, your pH. So your muscle function, your contractility of your muscles, and other important processes that we can get into later. But electrolytes are very important, and that's why they do testing on it. So troponin is actually a cardiac marker, right? They can tell if something's going on, right? And also thyroid function tests, they could tell, is what they'll test for palpitations, especially with the hyperthyroidism. All right, let's get into syncope. Okay, so what is syncope? Syncope is a sudden brief loss of consciousness with loss of postural tone, followed by spontaneous revival. So, have you ever seen somebody scared and they get some type of psychogenic effect? It's caused, you know, with an increase in an abrupt loss in blood pressure. And these people will just, faint on you, and you got to like protect them from hitting themselves. You can see them. I have a few stories about that. I've seen that on several occasions. I was given a IV class at an embassy overseas, and one of the diplomatic security agents was real excited about doing IVs. He thought it was a cool thing. Because none of these folks were medical people like ourselves, but everybody thinks that they're cool and they want more training, so they set up some training where we're giving them a tactical medicine class, and we went through the procedures on how to start an IV. And I was actually using a fake arm, an IV training arm, and I pulled out the catheter and I pulled it out and checked the integrity of it. And as I started inserting the needle into this training vein, you know, to go over some of the procedures. And we actually did IVs that day, but she didn't. She passed out right there in front of everybody. We had to catch her, and and another time, another guy did the same thing. So people just aren't used to seeing that kind of stuff, right? They'll just go ahead and pass out, and that's caused. There's uncommon. Some people don't know how it's caused, but they think it's the vasovagal, right? The most common, and sometimes it's idiopathic. Sometimes it's caused from drugs. People can faint on you, and disorders that decrease cardiac output. If someone has some type of valvular disease or cardiomyopathy, embolism, or arrhythmias, it may cause you to pass out. Also, if they have anemia, they don't have enough O2 running through their blood, right? And also low blood glucose. So, yeah, if you've got low blood glucose, you have a pretty good chance of passing out. So how do we evaluate syncope? We evaluate it by doing an HPI, an ROS, and a past medical history. So history of present illness, you want to notate the events leading to the syncope. Like, hey, we pulled out an IV needle and all of a sudden this person just fainted on the floor. So, what preceded that fainting? Or she experienced or he experienced some type of trauma event and passed out, or just witnessed something that was shocking to the system. Also, do they have nausea, sweating, visual changes, tingling of the lips or fingertips, any type of chest pain or palpitations? When you do your review of systems, make sure you go over areas of pain or injury, because it could have something to do with the syncope. Do they have bloody, when you get into their stools, do they have bloody or tarry stools, causing, some anemia, or heavy menses causing anemia, right? Vomiting, that could actually cause dehydration, which also could cause people to faint. Diarrhea, excess urination, this is all dehydration symptoms, or, immobilization. Past medical history, we want to make sure we get any previous events, family history, history of cardiovascular disease, seizure disorders. Has this happened before? Is this person doing this a lot? I have another example of a friend of mine who was a triathlete, and on the last occasion, he got rhabdomyolysis. Look that up. Anyway, I found him. He called me on his cell phone, right? And said, hey, I'm not feeling so well. This is the area where I'm at. I'm going to try to make it to the next gas station. And so he basically didn't make it there. So on my way to that gas station, I saw him off the side of the road. I rushed him to the hospital. And I had, at that time, at my age, I didn't know what rhabdomyolysis was. But he had a history of fainting all the time. He was one of those really obsessed individuals that just pushed the limits, right? His blood pressure, was so low all the time. And we'd be at the house. He was actually my roommate, when I was stationed in Texas. And he would get up and he would like fall down, and he would catch himself. Sometimes he wouldn't, and he would fall right in the living room floor, right in front of me, and I would say, "What's going on, man? You okay?" And he goes, "Yeah, I'm just training really hard and stuff." Well, it's a serious issue. I think he's okay now. He's just not as good a shape that he was in. But as you can see, it can become pathological when you're so obsessed with your triathlons and these kind of things. These people's blood pressures are, barely reaching 90, milligrams of mercury, systolic. You know, Even if it's really low, you got to really watch out for these folks. So yeah, so you want to get a past medical history for folks. They may be a really, training really hard, like athletes, and they may not have the electrolytes because they've been sweating a lot. Did they have a history of this, rhabdomyolysis, all these other things that are going on? You know, so you really want to watch them. Even healthy people can do this, right? And but yin and yang, right? You can't be too healthy because it's just kind of, you have to have some type of balance, right? Where you're not passing out, at least. Um, so how do we evaluate it? We do a physical exam, make sure to get good vital signs. Also, we want to get orthostatic blood pressures, right? So we want to make sure we get that. And what is orthostatic blood pressure? Yeah, so orthostatic hypotension is a drop of 20 milligrams of mercury, right, in systolic blood pressure, and 10 milligrams of mercury in diastolic when in the upright position, when the upright position is assumed. So they start off, uh, in a lying position or a supine, right? And then when they get up, you take their blood pressure and it drops that much, they have orthostatic. That's positive for orthostatic hypotension. They'll get the symptoms of faintness, lightheadedness, dizziness, confusion, blurred vision occur within seconds to minutes of standing, and resolve when lying down. So again, vital signs, check them for orthostatic blood pressure. Look out for that hypotension there. Their mental status, confused, definitely confused. Cardiac exam. You want to do a good cardiac exam that we covered week 1. Jugular venous waves, we talked about that. Abdominal exam. Want to make sure we do an abdominal exam. Why do we do that? We're looking for bleeding, any type of pain. They could have appendicitis. They could be bleeding internally. You want to check out their liver, look at their spleen, palpate and do all those necessary tests. Rectal exam for occult blood, right? And if they have occult blood, you want to refer them out. Make sure to gastroenterology, where they can actually diagnose and go in and see what's going on. We're always worried about cancer whenever we have blood, right? If it's bright red blood or something like that, we know that we covered that last semester, and that it's probably coming from hemorrhoids, but you just never know. You always want to refer out, let them make that call. Neurological exam to identify any focal abnormalities. And these are our red flags. So if they have syncope during exertion, definitely get them seen by somebody else, right? Multiple reoccurrences within a short time, like my buddy there in Texas. He's retired now, and he's not in too good of shape, but he's probably in better shape than a lot of people. Heart murmur or other cardiac findings. If they have any type of chest pain, we covered heart murmurs week 1. And if they are older age at initial episode, that's always a red flag, right? If this comes on suddenly, they never fainted before, we got to really look out for that, because there could be a multitude of things wrong, with the elderly when this happens. Significant injury during syncope, like a seizure, those are red flags, right? And family history of sudden unexpected death, right? So these are all red flags. So how do we test for syncope? We do an ECG. We do pulse oximetry. We talked about pulse oximetry in week 1. Also, we talked about the echocardiography. Pregnancy test in all females of childbearing age and a test for anemia. You want to get the HCT and ferritin, right? Measure that. We talked about orthostatic hypotension again. Remember this slide. This will you'll probably see this again on an exam. This is obvious down here, this last bullet, but this first bullet, I want you to remember those numbers. And what is the pathophysiology behind it? So you have gravitational stress of suddenly standing causes, blood to pool in the veins of the legs and trunk, and venous return decreases transiently. So sympathetic stimulation increases the heart rate, and thereby blood pressure returns to normal, right? And exercise or a heavy meal may exacerbate orthostatic hypertension. Etiology: most common causes of acute orthostatic hypotension are due to hypovolemia, bleeding. We touched on that a lot in Western Medicine 1. And, bleeding is a common cause for a lot of disorders, right? So we always want to be on the lookout for hypovolemia. And hypovolemia, our vitals are going ahead. They're going to go ahead and, you're going to have a low blood pressure, right? And you're going to have an increased heart rate. You're going to have an increased breathing rate with hypovolemia, especially in compensated shock. Those vitals will show that early on. You want to look out that it may be caused by drugs, right? Also, prolonged bed rests. Someone's in bed too long, their body is used to that. All of a sudden, they get up. They could be dehydrated. They've been sitting there for a long time, and all of a sudden they have a fainting attack as well because of orthostatic hypotension. And also, the etiology may be from adrenal insufficiency. The most common causes of chronic orthostatic hypotension are age-related changes in blood pressure regulation, drugs, and also autonomic dysfunction. Okay, so how do we evaluate it? We do the HPI, the ROS, right, and past medical history. So we want to annotate the duration, severity, and whether they fell or passed out or not. In relationship to meals, some people get postprandial tiredness, right, or postprandial fatigue, kind of like right now. You just ate lunch, you're listening to a recorded lecture, you're like, what's going on? Are you doing that? Now, this is going to give you an opportunity to study for your exams and your boards, right, your comprehensive exams. So yeah, postprandial fatigue is a potential. Also, you want to do a review of symptoms and symptoms of autonomic insufficiency. Autonomic, what's that? Relating to the nervous system. What controls our life, actually, our autonomic nervous system, right? Any type of visual impairment, incontinence, heat tolerance, or erectile dysfunction, you want to take a look at that. Past medical history, do they have diabetes? Do they have Parkinson's disease, cancer? All these things can put a toll, right, on our vitals. Any type of drug history or antihypertensives that they're taking, and of course, family history. So let's talk about the evaluation of orthostatic hypotension and the blood pressure and heart rate measured after 5 minutes supine and at 1 and 3 minutes after standing. So you're going to get 2 readings at 1 minute and 3 minutes after standing. You may assess while sitting upright if unable to stand, because some people will go ahead and faint on you if they have a history of this. If it's already been diagnosed and you're trying to be cool and everything and seeing if they're positive for orthostatic hypertension, be aware of that and be aware that these people may fall down on you. Skin and mucosa for signs of dehydration. Yeah, you can take a look at the skin. How's their skin turgor? Is it, when you pinch it, does it stay there? Kind of like that pitting, right? Except you pinch right here, top of the hand, and it takes a while for it to go back into the normal place. You want to take a look at that skin. Also, a rectal exam for occult blood, and we refer out. And autonomic reflexes, we want to refer out because it's kind of a neurological disorder, right? Red flags, bloody or heme positive stool, so blood occult stool tests. And you want to start looking about cancer right there, right? An abnormal neurological examination. Testing, ECG, right? Serum electrolytes, we talked about. Fasting glucose. So let's talk a little bit about fasting glucose. And fasting glucose, if you remember, is I think we covered it in Western Medicine 1. We talked about pre-diabetes. We talked about when a person's blood sugar levels during fasting are consistently above the normal range, okay, but below the diagnostic cutoff for a formal diagnosis of diabetes mellitus, okay. So together with impaired glucose tolerance, it's a sign of insulin resistance. In this manner is also one of the conditions associated with metabolic syndrome. So we want to stop or reduce suspected drug to confirm the cause, and a tilt table test, right? A tilt table test. What is a tilt table test? I told you I'd cover that. So a TTT, tilt table test, occasionally called the upright tilt testing, is a medical procedure often used to diagnose some type of syncope, right? And patients with symptoms of the dizziness, the lightheadedness, the confusion, or even loss of consciousness, the fainting. This is why it's you're always on the lookout for that. And this person falls and hits his head on the corner of the table while you're doing these tests. You're opening up yourself to some liability. But if you have the support and you're aware of it, you can actually do these tests, no problem. It's suspected to be associated with a drop in blood pressure, right? And or positional tachycardia as well are good candidates for this test. So if someone has, change in heart rate when they go from supine to sitting or supine to standing, you got to really look out for that. So, and that TTT will take care of that for both orthostatic and tachycardia, positional tachycardia. Hypertension. So this is, remember this slide, because you will see these numbers again, especially the top bullet. All right, you may see this on an exam coming up. So it's sustained elevation of resting systolic blood pressure, right? So if it's sustained and it's above 140 milligrams of mercury, equal to or above, and a diastolic, greater than or equal to 90 milligrams of mercury, or both. So you want to take a look at that. Remember those numbers, 140, 90, and it's sustained, all right? So a lot of people have this, 81% are aware, 73% are being treated for hypertension. So most commonly primary essential, chronically increased vascular muscle tone. And you're going to have hereditary environmental factors as well. Secondary is caused by kidney disease or aldosteronism. Okay. Let's see here. So this aldosteronism, as pronounced, is primary aldosteronism. It's also known as Conn's syndrome, C-O-N-N-S syndrome, and refers to the excess production of the hormone, of that particular hormone, from the adrenal glands. Okay, and this can result in high blood pressure. And many of these patients are also going to suffer from some type of eye disorder. They're going to have poor vision, and they have a potassium deficiency and high blood pressure, which actually causes poor vision, confusion, and headaches. So look out for that. Pathophysiology, abnormal sodium transport causes increased sensitivity of myocardium to sympathetic stimulation. So you have an increased sympathetic stimulation, a renin-angiotensin aldosterone system dysfunction, and a vasodilator deficiency, which is bradykinin, right? What is that? It's basically a protein peptide that promotes inflammation, right? It causes arterioles to dilate, enlarge via the release of a couple things like nitric oxide for one, prostacycline, endothelium-derived hyperpolarizing factor. It makes the veins constrict, right? That makes it constrict. Um, so yeah, so bradykinin is kind of tricky because when you have this protein that promotes inflammation causing the arterioles to dilate, right? But the veins are actually constricting. So that's, you got to know the difference between arterioles and veins with the bradykinin. Complications only occur after prolonged or severe hypertension and coronary artery disease and myocardial infarction. You're going to have heart failure, right? Stroke, renal failure, and death. These are all complications. So the signs and symptoms could be asymptomatic until complications develop. So people can go years with hypertension and be functional, and next thing you know they're starting to show these symptoms, which can include the fourth heart sound, the S4. That S4 is actually we're going to cover that in week 3. We're going to go over all those different sounds. We're going to do the EKG, ECG. We're going to go over that monitoring. But essentially what a fourth heart sound is an extra heart sound that occurs during late diastole and immediately before the two lub-dub sounds, which is S1 and S2. And it occurs just after atrial contraction and immediately before systolic S1. Okay, so that'll all become more clear next week because we're going to go ahead and break down all that stuff. But just remember, for hypertension, they're going to have that fourth heart sound. They're going to have retinal arteriolar narrowing and hemorrhages, papilledema, dizziness, flushed face, headache, fatigue, epistaxis. So these people will get nosebleeds. And nervousness are signs of complicated severe hypertension. Diagnosis. So you want to get readings of elevated blood pressure on 3 separate days because things could go haywire from one day to the next. You want to make sure we gather enough data to make sure that it's hypertension and not caused by some other psychosomatic event or something that they weren't doing normally. So we want to make sure that we get that taken care of. Classified as normal, pre-hypertension, stage 1 or stage 2 hypertension. Urinalysis, we can diagnose it by urinalysis, ECG, creatine, electrolytes, fasting plasma glucose, right? And lipid profile. And thyroid stimulating hormone tests should be done to determine coexisting conditions and rule out that hypertension. Here's some of the graph on the classification, what a normal blood pressure, elevated blood pressure. So if you want to remember some numbers, you may see this again on some board exams. Remember this slide and kind of come up, you should be able to draw this out. Right? Draw this out on the side prior to your test so you can refer back to it. The most common cause is messing up this right here, these two right here. These are the 2 common questions that are missed between normal and elevated blood pressure, because every time we see 120 over 80, okay, that sounds normal, right? But this is below. Normal blood pressure is below that, right? So even though someone comes in with 120 over 80, they're normally healthy, right? But the test question is going to look for this, right? And so they'll give you another, the way they word the question may throw you off. So make sure you pay attention to that aspect and the rest of them too. Like what is stage 2 hypertension? Know that as well, okay? Because you will see 150, there's other sources that'll say 150. And there's also, you may have a clinic rule that you can't treat anybody with a blood pressure higher than one of these. I don't know what it is, But if you have that clinic rule or policy, you should look into it because we can cause more damage. Okay, how do we treat it? Definitely want to get them to lose some weight, right? So people whose BMI is 24.9, right, possess the ideal amount of body weight, and you are healthy. You're a healthy weight for your height, so it's a ratio, right? So what is body mass index, BMI? Body mass index is associated with living longest, they say. You know, there's a lot of evidence to suggest that. And the lowest incident of serious illness, to include these diabetes and high blood pressure and all these things that are kind of like the triad, right, of making people unhealthy, cancers, even cancers, or some. So you want to make sure their BMI is 24.9 or less than, and yeah. So, and they're also, I mean, people look healthier when their BMI is under that, right? So you want to maintain a healthy weight. It's important for overall health and help prevent and control many diseases and conditions. This is why we're so into, in Chinese medicine, we're into moving blood and qi, right? The only way to do that is to move. So we want to make sure that we get these people to exercise at least 30 minutes a day, every day. Smoking is not so good for you, as you know. And smoking, you'll see a lot of risk factors involved with many diseases, right? And you're like, why is smoking that? You know, just because it says it right here, smoking cessation. Decrease salt intake, alcohol, and increase nutrient density of diet. And drugs, actually, if greater than 140 over 90, you know, they're going to get on some type of, you know, some type you know, modification, lifestyle change, drugs. These drugs may include hydrochlorothiazide, which is this acronym here, HCTZ. It's a diuretic, is often the first of choice. And combinations can be prescribed if the pressure is not normalized. All right. Goal of less than 130 over 80 if less than 80 years old, right? And these drugs, these thiazide type diuretics are the most common, right? We discussed what body mass index was, and we're getting into the drugs. So this HCTZ or hydrochlorothiazide, remember, is a diuretic, right? It's a medication often used to treat high blood pressure and swelling due to fluid buildup, like that picture we showed of edema. They would give that, right? So other uses include treating diabetes and renal tubular acidosis, and to treat risk of kidney stones. Other diuretics are loop and K-sparring, where the loop are actually, they work on the distal convoluted tubule, that loop up in there, right? So these different drugs treat different parts of the urinary system, which is kind of cool. Also, beta blockers, slow heart rate and reduce myocardial contractility. Calcium channel blockers reduce peripheral resistance by causing vasodilation. Remember beta blockers on this slide? Remember beta blockers, remember calcium channel blockers, and remember ACE inhibitors. These will come up again and again. Okay. And let's see here. And just these other, going back up to this loop and K-sparring, it's not as effective as initial drugs. Yeah, for that particular disease, but if they have something wrong with their kidney, then it's more effective. So, and remember these loop diuretics, they're diuretics that act on the ascending limb of the loop of Henle in the kidney. So if you need a review of that, go ahead and look that up, the loop of Henle. That's where loop diuretics are concentrating. They're primarily used in medicine to treat hypertension, and edema, and CHF, right, congestive heart failure, or chronic kidney disease. While thiazides, right, thiazides up here are diuretics that are more effective in patients with normal kidney function. As soon as you come down here to the loop, these are for poor kidney function. Right? All right, so I'm glad we got that knocked out of the way. And again, as you know, with hypertensive emergencies, we don't want to treat people if they're having an emergency, right? There's no way. We got to refer out. And sometimes we don't even know it, but they're having a severe hypertension episode with damage to target organs, brain, cardiovascular system, and kidneys. Typically considered an emergency if diastolic pressure is greater than 120 milligrams of mercury, right? Diastolic, that's the bottom number, right? Yeah, whenever you have that, you should not be treating a patient. You should get them referred out immediately and get them to a hospital. Signs and symptoms, rapidly changing neurological symptoms, right? These people are going to have confusion, transient blindness, hemiparesis, jugular venous distension, okay, with high blood pressure. Anybody know any time else that you get jugular vein distension? So, and I mean, it says, jugular vein distension when you have low blood pressure, right? But it also can be compartmentalized. Like if someone's having jugular vein distension here, there's high blood pressure in this area, right? Like if they have some type of, a compromised chest where they have a tension pneumothorax or those kind of things, there's going to be increased pressure here, causing that right atria to get backed up, on this side, right? And you're going to have distended neck veins, on both sides of your jugular veins. And then if you have lung crackles, right, at the base of the lungs, you're going to have severe retinopathy. These people, glaucoma patients, it could get a lot worse with high blood pressure. And you want immediate transport to the hospital if the pressure is high and other symptoms and signs are present. So if pressure is elevated but no symptoms are present, referral to urgent care or physician within 24 hours. Okay, let's talk about so when we're talking about atherosclerosis, remember that our immune system is oftentimes involved with this because we have an inflammatory response, right, to injury, to the endothelial lining, right? And so we get all kinds of response there, causes an inflammatory response and injury. And because of this tissue damage, it causes turbulent flow, blood flow to that area. So it's a patchy intimal plaques that block the lumen of the medium-sized and enlarged arteries, hence atherosclerosis. Contains lipids, inflammatory and smooth muscle cells, and connective tissue that's causing that turbulent flow. And it may be stable or unstable. So, so the risk factors involved is as we get older, we're going to have more risk of atherosclerosis. Family history for sure, male sex, and dyslipidemias, increased fat in the area. Here we come again, tobacco smoking. That's the major player. It's always the common denominator there. You can see that a lot in different other diseases and disorders. Diabetes mellitus, hypertension, which we've covered, alcohol intake, and high C-reactive protein. So high C-reactive protein is a ring-shaped or annular-shaped, ring-shaped protein, and it's found in the blood plasma. And the circulating concentration rise in response to the inflammation we talked about on the last slide It is an acute phase protein that they can pick up on during the C-reactive protein, right? It's an inflammatory marker and uh, increases, like the interleukins and the macrophages, and they can pick up on all that stuff, right? So its physiological role is to bind to the express surface of dead or dying cells and some areas, types of bacteria, but it activates the MAC, right, the complement system, right, and causes all that inflammation in that area. Okay, so symptoms and signs may be asymptomatic for decades. We're not going to know until you actually start, to receive and develop blood flow impedance. That turbulent flow that actually gets impeded a lot more. So you're going to get transient ischemic attacks, unstable angina, ischemic stroke, so rest pain in limbs, and aneurysms and arterial dissection. So how do we diagnose it? It's symptomatic. Patients are evaluated for amount and location of vascular occlusion, and testing will depend on the organs involved. I showed you in week 1, we saw how they can insert a catheter and go up and look inside, insert a dye in certain vascular components and see what's going on, where the occlusion is taking place. Testing, again, will depend on the organs involved. Screening of asymptomatic patients includes a fasting lipid profile, right? So we got that fasting thing going on. We have the angiography or arteriography that we showed in week 1. Plasma hemoglobin A1C. So that tells your average level of blood sugar over the past 2 to 3 months. So that's a good indicator, right, of what's going on. It's also called HbA1c, so for hemoglobin A1c. And people who have diabetes, so often have arteriosclerosis, so they're basically testing you regularly to see if their levels are staying within the range during that period. And it could tell if you need to adjust your diabetic medication. And so we also have, I think it's coming up, but we also have a coronary artery bypass grafting that they can do to bypass arteriosclerotic, the arteries in the heart, cardiac arteries. Let's take a look at that. So how do we treat it? So increase nutrient density, decrease caloric density of diet. So we want to increase our fiber, correct? We've always known that, and we're a part of that. We can actually provide Western medicine nutrition or Western nutrition factors as a part of our scope of practice. You may see that again on a test question. Regular physical activity, for sure. Get rid of the smoke sticks. Quit smoking. Quit inhaling these carcinogens into your lungs. Treatment of risk factors. Okay, aspirin. A lot of folks take aspirin 1 a day. A lot of people take baby aspirin and just chew them up. And statins if they suffer from high cholesterol. And coronary artery disease. You have, like I mentioned, the cabbage before, that coronary artery bypass grafting, which is a surgery provided to these patients. It's when you have impaired blood flow through the coronary arteries, it gets so bad they have to actually graft and bring oxygen-rich blood to the areas and bypass the blocked area, essentially. So pathophysiology is coronary arteriosclerosis at points of turbulence. And erythromatous plaque may rupture or split, causing a thrombus, which blocks the blood flow. That's serious right there. So you may get a coronary artery spasm, and transient focal increase in vascular tone, narrowing lumen, and reducing blood flow. If the lumen is already partially blocked, ischemia will occur and may be caused by vasoconstricting drugs like cocaine, nicotine, and emotional stress. Some of the autopsies coming out from these latest ration of, you know, unfortunate incidents where people die in police custody, you know, um, you know, the autopsy reports are saying they suffered from some type of ischemia, right? Now, of course, if someone's standing on your neck, it's going to happen, right? So, but if they have any kind of predisposing condition, it can actually exacerbate the situation and make it worse and causing deaths. And that's why they say cocaine, nicotine, and emotional stress can also exacerbate that situation. So risk factors, again, dyslipidemia, high LDLs, low HDL. So you want that, you want high HDL, right? And you want low LDL. Diabetes mellitus kind of go hand in hand. Smoking, obesity, especially abdominal obesity, sedentary lifestyle, high blood pressure, hypothyroidism. All right, so family history of coronary artery disease, CAD, and low nutrient density, high caloric density diet. So those are risk factors. How do we treat it? We treat it with lipid lowering drugs like our statins. You'll see a lot of those in people's medical reports, right? And you can annotate that, right? So aspirin to reduce formation of the clots, and beta blockers reduce the symptoms of angina, chest pain. Percutaneous coronary intervention is the placement of a drug secreting stent, and fibrinolytic drugs for acute thrombosis. Here's our cabbage, our coronary artery bypass grafting. Kind of looks like this. We'll have your bypass grafting using the saphenous vein, and they attach, here's your blocked artery, and then bypass graft using a mammary artery. So it brings, they bypass the blockage and insert oxygenated blood in a place just past the blockage. So it makes sure that the lower portion of the heart below the blockage is perfused. So it's called your cabbage. Angina pectoris is a syndrome of precordial discomfort or pressure due to transient myocardial ischemia without infarction. So there's a test question on here that you'll see again. Remember, is do you get angina with exercise or without exercise? Does a person get it at rest, or does a person get it while there's a workload increase? So that's really important to annotate because they're different. Okay. So arteries are narrowed by arteriosclerosis and artery spasm are both causing this angina pectoris. So remember that there could be some physiological things going on like aortic stenosis or aortic regurgitation that causes this pain. Also hypertrophic cardiomyopathy. Symptoms and signs of stable angina. So what is stable angina? I just kind of mentioned that on the previous slide. So stable angina is that you only get it when you're subject to stress or you're climbing, stairs or triggered by exertion, right, or strong emotion. So that's stable angina. So the ranges from vague, barely troublesome ache to severe, intense precordial crushing sensation. So there's going to be a variety of ranges, but know the difference between stable and unstable angina. Most commonly felt beneath the sternum, but it may radiate to the left shoulder, down the left arm to the fingers, or to the jaw. Okay, and yeah, that's definitely a red flag. Barely described as pain, rarely described as pain. Atypical angina perceived as GI symptoms. Folks will, get bloating, abdominal distress, or indigestion, typically triggered by exertion or strong emotion. persists more than a minute, but usually not longer than 5 to 10. And it subsides with rest. So if it subsides with rest, I would say that's stable angina. If it doesn't subside with rest, then it's unstable angina. Timing can be variable, several days to several a year, several a day to several a year. Symptoms of unstable angina is a red flag for impending myocardial infarction. As we discussed, the characteristic pain of angina for that patient is changed. Spontaneously occurs at rest. Okay, that's a red flag, right? That's unstable. Spontaneously occurs at rest. Remember that. Or if it's a new onset of angina that didn't occur before, that could be considered unstable angina. Or increased pain, longer lasting pain, right? Unstable. How do we diagnose it? Symptom picture through an ECG, stress testing with ECG or imaging. Of course, it's going to be contraindicated if angina is unstable. It can't really, not the ECG, but the stress testing. Okay. Coronary angiography for significant symptoms or a positive stress test. Prognosis, the main adverse outcomes, unstable angina, myocardial infarction, sudden death due to arrhythmia. So it worsens with increasing age and symptom severity. Your prognosis there. Now we can treat these patients. We can change. Basically, a lot of these patients, they need to change their lifestyle, right? And some of them you can't do it. They're too far gone. Some of them, especially those that are so damaged, it's hard to get them back. But if you can catch us early on, there's been some turnarounds with the change of lifestyle, change in nutrition, diet, so forth, self-care, etc., etc. Modification of heart disease risk factors. Here comes our smoking again, BP, lipids, and lifestyle. Antiplatelet drugs, beginning with aspirin, beta blockers, nitroglycerin sublingually for symptom control. A lot of folks that have this will carry a bottle about that big. It's got these little tiny nitroglycerin tabs in there. So sometimes, they'll ask you to assist in putting it underneath their tongue. Relief should occur within 3 minutes and last 30 minutes. The drug deteriorates quickly, so make sure that prescription is up to date. And those who have angina or have been scared, they'll be carrying that nitroglycerin around. And they'll often will feel tingling under the tongue and may cause a headache with the nitro. And of course, the treatment is the cabbage or stent if symptoms worse or become unstable. Heart failure, also called CHF or congestive heart failure. This is failure of the ventricles, right? The left ventricular failure causes shortness of breath, fatigue, cardiac output decreases, pulmonary venous pressure increases, and fluid extravasates into the alveoli. Yeah, so let's go back to that slide. Let's go ahead and remember that particular bullet there, that the left ventricular failure causes shortness of breath, fatigue, and that cardiac output decreases while pulmonary venous pressure increases. Important slide. This develops in ischemic heart disease, hypertension, mitral or aortic valve regurgitation, aortic stenosis, cardiomyopathy, congenital heart disorders. So that's your left ventricular failure. Let's go over to the right side, where you have right ventricular failure causes peripheral and abdominal fluid accumulation. If you take a look at the anatomy there, that right ventricular, right down there below, if it fails to pump, right, systemic venous pressure increases, so causing fluid extravasation and edema in dependent tissues and the abdominal viscera. This is most commonly caused by left ventricular failure. So right ventricular failure is caused by left ventricular failure, and eventually failure of one side will lead to failure of the other side. Key point there as well. All right. Signs and symptoms. When you have left ventricular failure, you're going to have dyspnea due to pulmonary congestion. right? And those alveoli are getting saturated. As failure worsens, this can occur during rest and at night. And fatigue due to low cardiac output. The patient will be tachycardic, uh, tachypnea, cyanosis, including warm areas, literally displaced pickable impulse. Inspiratory crackles that do not clear with coughing. So they're going to be backed up, right, with that CHF. Um, right ventricular failure, you're going to have non-tender peripheral pitting edema of the feet and ankles. So that's a slide. If you see something, a question that says true or false, left ventricular failure causes non-tender peripheral pitting edema of feet and ankles, you would say false, right? But sometimes there's a combination. But understand that right ventricular failure, non-tender peripheral pitting edema of the feet and ankles occurred. Fatigue for sure. So what's in common? Both left ventricular failure and right ventricular failure have fatigue, right? One side has nocturia. So you're going to need to do a differential diagnosis. You do it with Chinese medicine. You're going to do it here as well. So what do they have in common? Well, they both have fatigue. What do they have? What side has nocturia? Right ventricular failure. What side has pitting edema of the feet and ankles? That would be right ventricular failure. And hepatomegaly, right, and ascites is common with right ventricular failure. So you're going to have that liver involvement, right? And again, the elevation of jugular venous pressure and distended neck veins on that right side, right? We talked about the right side. We were talking about the atria, but still, if it's on the right side, you're going to have elevation of jugular venous pressure in that area. Okay. Heart failure. How do we diagnose it? We do this by clinical evaluation. We do chest x-rays that shows enlarged heart. A lot of us have enlarged hearts. You know, we exercise tremendously as younger adults and kids, and causes an enlarged heart. Some folks have pleural effusions, and the ECG can show previous myocardial infarctions, and it shows up. We're going to cover EKG or ECG next week. They're going to have left ventricular hypertrophy, right? So a bundle branch block. So you'll learn that next week as well about right bundle branch blockage. You know, people die from these things. So echocardiography to evaluate valves and look for thrombi, tumors, calcifications within the heart. Okay. So, okay, the 1, 2, 3, 4, the fifth line here, the serum NP, BNP is elevated, right? It's elevated in heart failure, but not with COPD. So with the serum, it's a natriuretic peptide test that they use. And what are these? They're peptides that are substances that are made by the heart. And two main types of these substances are brain natriuretic peptide and N-terminal pro-B type. And normally only small levels of this BNP are actually found in the bloodstream. So whenever there's high levels, it indicates that your heart isn't pumping as much as your body would need. And so when this happens, it's known as heart failure. So they could use this test to diagnose, but also test the severity with somebody that's already been diagnosed with heart failure. Okay, so complete blood count, creatinine, BUN. You want to get the BUN, right? Electrolytes, glucose, albumin, liver function, thyroid function to help determine etiology and the severity. Treatment, we want to diagnose and correct the cause. Again, hospitalization with acute or worsening heart failure, or if they start to get pulmonary edema. Okay, it can be a downhill slope really fast for these folks. Monitoring daily morning weight to detect fluid accumulation early. Okay, want to make sure we get on top of it and stay on top of that. of our patients. And what else can we talk about on treatment? Try our best to change your lifestyle. Damage has been done, but there have been recoveries from heart failure. And at least we can try to help with their quality of life, right? And adjust dose if weight increases, right? If there's more than 2 kilograms over a few days. And drug therapy. We have our diuretics, our digoxin, which we mentioned earlier in this lecture. We have our ACE inhibitors and our beta blockers. All right. So last week, we talked about the cardiovascular exam. We talked about the echo. We talked about a stress test, cardiac catheterization, showed you pictures of what that looks like. We talked about chest pain. We talked about edema, pitting edema, what that looks like, what it's caused by. This week, week 2, we talked about palpitations and syncope. We kind of went in depth on orthostatic hypotension. There must have been 4 or 5 slides on that, going over that. Hypertension, we discussed hypertensive drugs and the emergencies involved with hypertension, and we also talked about patients that we shouldn't see and we should refer out. Red flags, atherosclerosis, remember the damage caused and that parabolic flow versus turbulent flow. Whenever there's turbulent flow, we have some type of inflammatory process causing tissue damage in the area, causing eventually a blockage. We talked about cabbage, and we talked about coronary artery disease. We talked about chest pain and angina, and we talked about heart failure and specifics on heart failure. So thank you for listening up today on today's lecture. Next week, week 3, I look forward to going over some ECG monitoring and what those PQRST waves are telling us, and also get into the exercises. If you want to take a look at the quiz, I think at this point you'd be able to pass it, but you may be working ahead of the schedule a little bit if you attempt to do so. Hit me up on email. If I'm going to send out a group email right now, giving you a link to this YouTube, right? And so, I don't know why I'm telling you this, because you'd be watching this, but in case you got a hold of this, understand that it's going to come in the future. They're going to be coming via email, and it will give you a link to a YouTube video. And I look forward to next week, and good luck on your comprehensive exams, and good luck on your studies. So you guys have a outstanding weekend, and I want you to take care. We'll see you soon. Bye now.